I have the pleasure of introducing Dr. Allison Carroll and Dr. Amy Van Pelt, who are both core faculty at the Center for Dissemination and Implementation Science, and both superstar methodologists in implementation science. They are going to be talking to us today about determinants of implementation, and I'm going to let them take it away.
Thank you so much, Sarah. Appreciate it. So I'm Allison Carroll. I'm going to go ahead and get us started today. So as we mentioned, we are today talking about implementation determinants. And we're going to provide an overview to start, and then we are going to walk through in more detail one framework in particular, which is the CFR, or the Consolidated Framework for Implementation Research, which most people, if they've heard of one framework, this might be it. We'll also talk a little bit then about how to actually apply it, like what you do with this to identify your determinants. We will then move to centering equity within the concept of determinants and walk through our case examples before breaking into our discussion groups. All right, so getting into this, our learning objectives and what we're hoping that you'll take away today is to describe how to frame and analyze the context for D&I research, to assess, describe, and quantify, where possible, the context for effective D&I, to identify appropriate conceptual models, frameworks, or program logic for implementation determinants, and then also to describe the importance of incorporating the perspectives of a variety of different groups for understanding D&I context. So diving right in, what are we talking about when we say determinants of implementation? Well, not to use the word in the definition, but it determines what works, where, and why. And in particular, the questions that we're asking here are, why does an intervention or innovation work or fail in a given context or setting? And also, why does a given implementation strategy work or fail based on the setting or context that it is implemented in? And the thing about determinants, this is a neutral term, and it is on a spectrum that can go from positive or negative to negative, where when something is a positive determinant, that means that it facilitates implementation, call that a facilitator. When it's on the negative side, when we're lacking that, then it becomes a barrier to implementation. This is where we get this term of barriers and facilitators. Another way to think about this, I was a little confused by the term determinants when I first came into the field. And something that was really helpful for me was thinking about this from the idea of social determinants of health. And so when you think about something determining health, an example is socioeconomic status, or SES. And this can be on a range from low to high SES. When it's low SES, that becomes a barrier to health. As a determinant of health, low SES becomes a barrier. Whereas when somebody has high SES, that tends to be a facilitator of health. So hopefully that's helpful for you in thinking about how, when we're talking about determinants, we usually identify them neutrally, but then say like, oh, but this becomes a barrier, this becomes a facilitator. The determinants of implementation may also act as moderators or mediators, depending on how you look at them within your full model. And this is often where people start, and it can be really useful for laying a base or foundation to guide formative evaluation. So to put this in our terms, our layman's terms, when we talk about determinants, we're talking about the conditions that make it harder or easier for people to do the thing. And so again, as you can see here, as it's laid out in the implementation research logic model, we're starting on the left. This is laying the basis for all of the implementation that's to come next, for selecting and specifying your strategies, for assessing the mechanisms, and ultimately evaluating the outcome. So that's where we're at today. And on the next slide, just one more way to continue to orient yourself from these figures that you've already seen. Just as a reminder that all models are wrong, but some are useful, and the only incorrect model, theory, or framework is one that is misapplied. We are pretty directly here in this determinants framework box down in the bottom here. We're using our determinants frameworks because we want to understand and or explain what influences the implementation outcomes. Next slide, please. So as kind of a very summarized version of all of this information, context is really central to implementation. The context matters. And that is why there are 17 determinants frameworks that were identified in a review that is now 5 years old. And there have been many more developed since then. And in just a second, Amy is going to talk through one. But again, just to give you a sense, there are so many that are specific to different contexts and settings. So there's a lot to explore out there when it comes to the determinants and context. With that, I'll turn it over to Amy.
Thanks, Allison. Thanks, Dr. Carroll. Just really to emphasize one more point here, as you mentioned, context is central to implementation research, and to put on another lens or another perspective for folks who may come from different types of research. In traditional efficacy or effectiveness trials that you all may be more familiar with, we often try to design or control for differences between sites, but in implementation science, context is not seen as a problem, and it really truly influences our implementation process. We wanted to concretize this concept with a very basic example that we hope everyone will be able to follow before we dive into this framework or into some of the frameworks. So if we have an example here where the thing we're trying to implement is a mobile phone application, but the setting in which we're trying to implement the intervention or implement this thing does not have smartphones, then implementation is going to fail. And we'll walk through a framework that'll help us think about different levels of determinants, such as a lack of resources, like this example, that may affect implementation. As Allison mentioned, one of the most popular frameworks for understanding context is the Consolidated Framework for Implementation Research, or CFIR. And Dennis or Dr. Lee mentioned this framework in the last session, so we won't spend a ton of time on it, but we did want to highlight it one more time. CFIR, it truly is a framework for the systematic evaluation of factors that affect implementation across ecological levels. Essentially, CFIR is a meta-theoretical model, meaning that it was developed by synthesizing prior theories, models, and frameworks. And this is helpful because one of its strengths is that it's quite comprehensive. It consists of 5 domains and many constructs that we can talk about in the next couple of slides. But one of the limitations of this framework, and from my perspective, the state of the field of implementation science in general, is that we don't have a way to understand the relationships or the interactions between the constructs and the domains. Nonetheless, the original CFIR, that you can see in the top article here, was widely used in over 375 studies to assess implementation context and progress, as well as help explain findings, for example. And those findings were the barriers or the facilitators to implementation with regard to different domains. And this last point here, before we dive into the details of the framework, just want to mention that given that CFIR is so comprehensive, we wanted to emphasize that it's really important to think about the constructs that you're selecting that are the most relevant to your study and not try to use everything that exists in this framework. So let us know in our small group discussions if you have any questions about the original CFIR, but we did want to just pivot to highlight that there's an updated version of this tool. And I believe you all read this paper for the session today, so we won't describe CFIR 2.0 or the updated CFIR in too much detail, but we do want to highlight just a couple of the motivations for the changes between the two frameworks. So you can see here on this figure, the updated model really increased the applicability of the work or this tool by replacing the term intervention to innovation to be more comprehensive and referring to what the thing is that we're implementing. It also increased the specificity of the actors, and what I mean by that is the patients were replaced with recipients to refer to individuals that were intended to benefit from our innovation. They also added the concept of deliverers, which was to specify the individuals that would be involved in delivering the innovation. And want to mention that CFIR 2.0 or the updated CFIR still does consist of 5 domains. Those are just now labeled or now called outer setting, inner setting, innovation, individuals, and the implementation process. So starting with the outer setting, this domain refers to external factors that affect implementation, such as government policies. And as I mentioned, we'll talk about these at a high level because we'll have an opportunity to discuss both case examples in great detail. The inner setting refers to internal factors that affect implementation, such as clinic structures. Innovation refers to components of the thing. Individuals refer to factors related to the people involved with implementation, such as self-efficacy. And finally, implementation process refers to how to implement the thing. And folks often conceptualize this domain as implementation strategies, which you'll learn about in the next session, I believe, with Allison. So understanding these various determinants frameworks is helpful, but one of the most common questions that I get is when and how do I use these in my research? And before I answer that question on the when and the how, I wanted to just clarify the what. So you may have heard of the phrase or the concept of contextual inquiry. And I know that I've recommended in consults to folks, go do contextual inquiry. And folks agree, but then they ask, what is the contextual inquiry method? So just to clarify and level set here, when we say contextual inquiry, we quite simply mean asking about the context to understand the determinants. So when do we do contextual inquiry? Both as I would say, I was an epidemiologist and an implementation scientist, my favorite phrase is it depends. And it really does depend. When we do contextual inquiry, it depends on various factors. The main one being whether or not the intervention or the thing already exists in our setting. So if we're planning on implementing a new thing into a setting, of course, folks won't have experience with the intervention or with the thing. And when we ask about determinants before experience with this is often considered pre-implementation inquiry. On the flip side of that, if you ask about barriers and facilitators and determinants after the thing has been implemented, whether that's by your research team or because the thing had already existed in the setting, then that's post-implementation contextual inquiry. And as you would expect, there are both pros and cons with the timing of this contextual inquiry. For example, we would be hypothesizing what the determinants would be if it's pre-implementation contextual inquiry versus actually having experience with the thing. But regardless of the timing of when we do this process or this line of questioning, gathering this information is really helpful for informing implementation strategy selection and tailoring. So how do we do contextual inquiry? How do we identify implementation determinants? And this goes back to my point a couple of slides ago where I mentioned that contextual inquiry is this line of questioning, and the approach actually follows methods that I'm sure you all are probably familiar with. So we can identify implementation determinants through qualitative methods such as semi-structured interviews or quantitative methods such as surveys. And for folks who are interested in mixed methods approaches, one approach involves conducting interviews to identify implementation determinants and then administering a survey to have folks sort of rank the strength of those identified determinants, for example. And for all of these approaches, it's really helpful to design your data collection instruments by your implementation determinants framework. And I want to just pause and emphasize that point for a moment, because anyone who may be writing an implementation science grant in the future, this is a really important thing to keep in mind. It's great if you can identify a relevant framework for your work, but you want to make sure that you actually integrate that framework throughout your research process. And one way to do that is by using it to inform data collection and inform your data collection instruments. Of course, analysis and the rest of your work that comes later as well. Another key point that we wanted to highlight when you're considering how you're collecting this data are your participants. Who are these key constituents that you're interviewing or administering your survey to? And depending on the setting, key constituents may be healthcare workers, leaders of your clinic, Ministry of Health, etc. And I will pass it back over to Allison to talk about how we're centering health equity.
So in the next slide, yeah, we can see, hopefully you're already kind of thinking about some of the limitations and really coming at this with a critical eye in how we're using our various determinants frameworks and how we're just thinking about assessing the context. So as we mentioned up top, not all frameworks are going to be relevant to all settings. Some of the changes that Amy pointed out in the change from CIFR 1.0 to 2.0 was to try to broaden the settings to which it might apply. It was more traditionally thinking about healthcare, not exclusively, but that's, it talked about providers and patients. And now it's broader in terms of all of the different roles and recipients instead of just being focused on patients. So that's just one example. There's also been minimal integration of health equity in the assessment of, and at least how the theories, models, and frameworks assess the context. I'm going to show you one example of where this has been done, but it's something for you to be thinking about and considering as well, and how you would want to assess health equity when you're informed by a theory, model, or framework. There's also not a great understanding of the mechanisms and how that functions, as we move to the right along our implementation research logic model, starting with our barriers and facilitators. So these are they're great starting points, but we hope that you're able to think a little bit more critically, think a little bit beyond these determinants frameworks. So some of the ways to address these limitations, again, just building on what Amy just pointed out, we really want to make sure that we're including all of our constituents, all of our partners' perspectives, not only in the contextual inquiry, but also in the development of any further or redevelopment of any theories, models, or frameworks. Making sure that you're including all of those who could be affected by implementation is going to make for a much better rounded, more holistic look at the context. And this number 3 here is so tricky. It's something I'm sure that you're all recognizing, where you're drawing parallels between implementation science and your own area of research, where there's probably a lot of things that are really similar, but we just use jargon in our fields that makes it then hard to have any sort of crosstalk. And so working to make terminology consistent, especially for our non-research partners that we're working with, is going to lead to this bottom point here of greater generalizability on the concept of context, so that we can better communicate and collaborate across settings, across contexts, to identify those strategies that are going to be helpful to address the barriers and facilitators that we identify. So to that point, on the next slide, the one framework that has been developed is the Health Equity Implementation Framework by Dr. Woodward and her colleagues. And this first came out in 2019. And they recognized this gap in our implementation frameworks, that there really wasn't a good focus on health equity. And so they combined the ISRC framework, which is a pretty traditional implementation science determinants framework, with the healthcare disparities framework. And so the purpose of this framework is to explain the factors underlying differences in healthcare for vulnerable populations. And they focused on 4 factors. So number 1 was the patient themselves, for example, considering their beliefs about treatment. Number 2 was the providers, and thinking about, for example, the time that providers have and how their schedule functions. 3 was the clinical encounter, which includes the patient-provider interaction, all the communication that takes place during that visit. And then 4th, also, of course, thinking about the healthcare system. So this might be the hospital's commitment to reducing disparities, or its overall culture regarding quality improvement in the delivery of healthcare services. And by considering all of these factors, the hope is that, of course, it will lead to successful implementation and also at the same time improvements in health equity. So again, you can see this, the limitation of this, it is very focused in a healthcare setting, and yet it is really trying to integrate implementation and health equity together to improve both at the same time.
Thanks, Alice. Thanks, Allison. I'm slightly biased with this next consideration, given that I'm a global implementation scientist, but I do think it's important that everyone thinks about this, given there's an inequity in the application of implementation science between high-income countries and low and middle-income countries. So as you may have realized going through the literature, a lot of our tools and our determinants frameworks were developed in high-income countries, which presents limitations for the application in low and middle-income countries. For example, we have constructs that are not relevant to resource-limited settings, or these determinants frameworks may be missing important concepts in global health that we need to consider when we're implementing in this setting. There are also other accessibility concerns, such as linguistic barriers to tools, because they're primarily available in English. And to highlight this with a framework that we're all very familiar with now, there was a systematic review of the use of CIFR in low and middle income countries, which highlighted that there were both constructs that were not compatible in these settings, and they also identified a need to propose a new domain called characteristics of the system that related to things like external funding priorities and resources that are important considerations in this context. So we mention this because we think it's important to continue to assess the relevance and the appropriateness of our frameworks. And pass it over to Allison to talk about case example number 1.
So just as a reminder, I'm going to go through these first couple of slides relatively quickly. But this first example is about screening and brief intervention for risky drinking in level 1 pediatric trauma centers, where the gap was that there was a mandate to provide this type of intervention, but the rate of doing so is actually quite low. And so the team identified a protocol to be used, and the innovation, the thing. And now we're focused on that third bullet point of assessing the barriers and facilitators to doing so. So in the next slide, we'll start building, focusing on creating a blueprint or logic model. Building the IRLM, so started by specifying the thing and also the clinical outcomes. So this is a screening and brief intervention protocol that was recommended by national organizations, and the primary outcomes of interest clinically were patient follow-up with primary care and reduced drinking. And then when it came time to think about specifying the barriers and facilitators, the approach was to, number 1, review the literature on barriers and facilitators already to this screening and brief intervention protocol, and then also consulting and surveying the partners that they had within the systems in the trauma centers. And so I know this is really small, so I'm going to show you, sorry, if you could actually go back one, Amy. So from the literature on the left-hand side was identification of facilitators of the implementation of this screening and brief intervention protocol, which included committed leaders, intra and inter-organizational communication and collaboration, provider buy-in, and model acceptance, and then also quality assurance. On the right-hand side was an article that detailed the factors that were key for sustainment of this protocol. And the factors identified there were the presence of champions, the availability of funding, systemic change, and then also the characteristics of the practitioners who were actually conducting the intervention itself. All right, next slide, thank you. And so when they looked at these factors and surveyed the partners, what you can see is that then this was put into the barriers and facilitators, the domains of CIFR. So from the outer setting, you can see that the mandate for this coming externally and saying, hey, all of you centers have to do this, that's a facilitator, right? There's somebody externally who's like, this is something that's really important. We really want you to do this. Also funding. Funding is a huge barrier at times if we don't know where it's coming from or how much it's going to be. In this case, the money was available, it was there. So that was a facilitator. And that's indicated by those little plus signs that you can see at the end of the list. On the other hand, in the inner setting, the second box, the lack of integration into the EHR for this protocol, this workflow to take place, the lack of communication across groups. If you remember, that was a critical one that was identified as an implementation facilitator if there was good communication collaboration. That didn't really exist so much here. And then also there was inconsistent support from the organizations. And so all of those intersetting factors were much more on the barrier side. These were things that were going to have to be addressed in order to succeed with implementation. In the individuals category, there were a lot of different constituents, a lot of different levels of providers who were involved here, and buy-in was really varied across those different levels. So here you can see that there's both a positive and a negative. So those people who did have buy-in and engagement, facilitator, great. Those who weren't, though, becomes a barrier. Similarly, for the innovation, there were some components that people were like, yeah, that sounds great, that'll be helpful, and others that weren't, or people had different ideas about what would be helpful or not about this innovation. So again, kind of a mixed bag, and we'll have to see how it plays out with the strategies that we select. And then the same goes for the process, this needing to build it into the workflow. That doesn't exist yet, so it can't exactly be a facilitator, but there's hope that it can be. It's something that can be integrated into the workflow and become part of the habit, thus hopefully making it a facilitator as we move forward. And so next time we'll talk about the strategies then to address those barriers, and Amy will take the second case example.
Great. So for the group who may lean more public health, I wanted to just refresh our memory about case example number 2. This research aimed to understand the context of PrEP implementation among local health departments in the US. PrEP is our thing. This is an evidence-based medicine for HIV prevention. And for this research specifically, they examined oral PrEP, which is in the form of a daily pill. As I mentioned, the clinical effectiveness outcome is the prevention of HIV infection. So to understand the barriers and facilitators, this research team, they administered a cross-sectional survey, so one of those quantitative approaches, and they administered multiple surveys. So in the first round survey, respondents had to indicate their level of engagement with PrEP. And if they stated that they are engaged, then a second round survey was administered that included questions to, 1, further assess the means of engagement in PrEP, intentions to expand engagement in PrEP, and resources needed to advance PrEP implementation. On the other hand, if they stated that they were not engaged in PrEP, then the second round survey included different questions, including questions to assess PrEP awareness, knowledge, and interest, potential future engagement with PrEP implementation, and resources needed to initiate PrEP implementation. Through all of that data, they organized their key findings through CIFR domains as well. So looking at the top box here, with regard to the outer setting, some of the barriers included concerns about financial access to PrEP for individuals who wanted it, as well as poor reimbursement from third-party payers. With regard to the inner setting, some of the barriers included limited staff capacity, a lack of clinic guidelines on what they should or they could do, and a lack of support from health department leadership. With regard to individuals, they described a lack of understanding and awareness of PrEP among staff, as well as a lack of healthcare providers' willingness to deliver PrEP. And finally, with regard to the process of implementation, clinic workflow and time were both mentioned as challenges. And I want to emphasize that last point because I feel like time is often one of the most commonly identified implementation determinants when we're implementing or we're integrating a new intervention. So to wrap us up here, I think we're getting close to our time. We learned again that implementation determinants are these conditions that make it harder or easier to implement our thing. And this is all about the context in which the thing would be implemented. And we can leverage this information to inform the development of implementation strategies or the actions that we take to implement this thing. And Allison will spend the next session going into the details of this. Before we break out into our small groups, we did just want to let you all know that we included some additional resources that may be helpful when you're actually applying this to your work. Here are some additional tools and resources for using CIFR. Specifically, there's a website that gives detailed definitions for each of the domains and constructs, as well as helpful tools for data collection and matching determinants to implementation strategies. These next 2 slides are just an example of the health equity implementation framework. And you had an entire lecture on theories, models, and frameworks in the last session. So we wanted to spend more time discussing the how and the application of these tools. But we did include 2 additional determinants frameworks that you could explore on your own if you think they're relevant to your work. One is the theoretical domains framework. And looking at this slide, you can see that it's also a very comprehensive framework. And finally, PRISM is another framework that may be of relevance for you all. I think we're right at the mark here. So I wanted to see from the learning team if there's anyone that has quick announcements before we suggest a couple of discussion questions for the group.
Wonderful. We do have a quick announcement from the Center for Dissemination and Implementation Science. I also want to direct small group leaders to look at the chat because there are some outstanding discussion questions that have been put in the chat that I think would be wonderful for folks to follow up on as time permits. But wanted to note that we are hosting some interactive implementation science discussions with Brian Mittman, who's a national leader in implementation science, on Friday, February 23rd. These will be in-person discussions. He is traveling here from California, and we're having a 90-minute interactive discussion about a handbook for learning health systems that will be co-facilitated by Cindy Barnard, who's one of our students this year, and Pat Franklin. And then there will be an afternoon session about best practices for implementation science, coordinating centers and initiatives that I'll be co-facilitating. And if you're interested in attending and you did not get the invite, please email us at cdis@northwestern.edu to let us know of your interest. Please also, if you haven't gotten the invite, it might mean you're not on our listserv. So please feel free to email us at cdis@northwestern.edu to ask how you could get engaged in the listserv because we put out a lot of ongoing events. I'm going to quickly toss it to Dennis Lee to announce an opportunity for pilot funding.
Yeah, thank you, Sarah. So I just want to quickly announce that the NUCATS, so the Northwestern University Clinical and Translational Sciences Institute, the NUCATS Translational Science Pilot Awards, our RFA is now live. Application is due April 19th, 2024. I'm putting the link in the chat. This is a really, really great funding opportunity for folks trying to establish some new data or break into some more implementation sciencey things. Last year, we had 3 outstanding pilots that were awarded. All of them had implementation science components to them. So I highly encourage you to use the CDIS consultation if you're thinking about a project and talk to us about framing something for this award opportunity.
Wonderful. And I think we can break to small groups.
Yeah, I think so. As Dr. Becker mentioned, there's a lot of great questions in the chat. Feel free to use those to guide your conversation. If you all run out of thoughts, we have a couple of additional questions that we pose thinking about how determinants have acted as barriers and facilitators in your own work, even if that was not implementation research, how you've gone about identifying the determinants in your studies, and how you would think about centering health equity further in the contextual inquiry process. Okay, let us break out, I guess.